Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome to Open Mics with Dr. Stites. Today we're going to begin with an update on a carbon monoxide leak that brought patients to our health system yesterday. We treated 16 patients. 6 of them needed hyperbaric oxygen therapy. Now what this involves is using a highly pressurized chamber that pushes a higher concentration of oxygen into your lungs to force bad gases like carbon monoxide out of your lungs. To help explain what that is and carbon monoxide, we're joined by Dr. Steve Thornton. He's an emergency room physician and a certified toxicologist and the medical director of the Poison Control Center here at the University of Kansas Health System. Dr. Thornton, talk to us about what hyperbaric oxygen therapy is, what it does, how it worked, and how these 16 folks are doing.
So it is exactly what you said. It's basically a method to deliver, if you want to think about it, massive amounts of oxygen by giving patients 100% oxygen under pressure. So it's like you're squeezing more oxygen into a space, if you want to think of it that way. And yes, what it does is basically get rid of every other gas, whether it's carbon monoxide, nitrogen, whatever it may be. So it's a useful tool also in other sort of problems like wounds and things of that nature, and that's where it's probably used more commonly. But it is certainly one of our treatment options for carbon monoxide poisoning, because carbon monoxide is really the perfect poison. You can't taste it, smell it, see it. The only way you know you're being poisoned is when you start having symptoms. And those symptoms affect the brain primarily, and actually can cause delayed symptoms. So folks can get poisoned, get a little bit better, and then later on begin to develop symptoms again. And that's what hyperbaric oxygen therapy is. That's why we do it, is to prevent that delayed effects. And it's our really our only treatment at this point that's been shown to help with those symptoms.
So tell us about a couple of things. So first of all, you said it's a perfect poison. I'd say that makes it a really dangerous poison, because there's no really way to know you're having it until you pass out, and then you don't really know it.
Right, exactly. Its warning signs are basically, hey, I'm getting very sick, and passing out is a very common complication or sign of poisoning from carbon monoxide. Carbon monoxide is actually the #1 unintentional poisoning death in this country. Kills hundreds of people every year. It sends hundreds of thousands to emergency departments every year. So it's a huge deal. That's why we recommend every house have a carbon monoxide detector.
So we got to get to that point. This is why you have a smoke detector, but also a carbon monoxide detector in your home. So how many of these hyperbaric chambers do we have?
So we have 2. We're one of the larger. We're actually, the University of Kansas Health System is really the only 24-hour emergent hyperbaric chamber center in this area. So we're the ones who take care of situations like this. Exactly.
So you mentioned there's this delayed effect of carbon monoxide. Tell us a little bit about that. So you start to get better, you get some oxygen, and then all of a sudden things begin to get worse.
So what we've seen in studies of carbon monoxide is folks who get poisoned, who have symptoms like passing out, headache, they will get better with oxygen. They'll get better with removal from the source of the carbon monoxide. And then over maybe the next week or so, they start to feel the symptoms again, and they come back, and sometimes they're worse, sometimes they're less, but many times they're very, very debilitating. People talk about not being able to think right and personality changes. So they're very concerning symptoms, and people have often have done a lot of studies to try to figure out why this happens. We don't really know exactly why, we just know it does happen. But we do know that in studies, hyperbaric seems to kind of prevent that, kind of keep that from happening. So that's why hyperbarics is really the treatment, is a recommended treatment for carbon monoxide.
So how long do people have to spend in these chambers?
So it's a little longer than you think. So we actually recommend 3 treatments over 24 hours. So they're in the chamber for 3 hours, they come out, and then they go in for another 2 hours, and they come out and they go in for another 2 hours. So you're talking about 7 hours, 7-8 hours in these chambers.
And when you're in the chamber, you're reading a book, watching TV, what's going on around you?
Hopefully you have some Netflix series you want to catch up on, because you're doing a lot of watching TV, movies. You can't. There are very specific rules about what you can bring into the chamber, because as many people would surmise, a lot of oxygen, it creates a flammable environment. So you got to be very careful. That's why we have specially trained techs. We have guidelines, rules, very, very, very carefully controlled process. But yeah, hopefully you do have something you want to do some binge watching on, because you're going to have some time.
So what you're really saying is that smoking a cigar while watching a replay of Super Bowl 57 is not the way to do it. Is that
would be highly inadvisable in a hyperbaric?
Got it.
Yes.
Got it. Okay. So let's see if there's any reporters on the line with any questions about that. None? All right. And so today, Dr. Thornton, those patients are doing well so far, those 16 folks?
All of them have gotten hyperbaric. The ones that needed hyperbarics have gotten it, and they are doing well. And right now, we're thinking everybody's going to do fine.
Good. And this is one of the larger carbon monoxide outbreaks we've seen in a while.
It's one of the biggest I've ever been involved in, yes.
Yeah. Well, let's not do that again. I think it's highly inadvisable.
I agree.
I'm glad someone figured out, they were awake, what was going on, so those good folks could get to the right medical care. All right, Dr. Thornton, thank you very much. We appreciate you being with us on the program today. Now we're going to pivot. Yeah, we're going to pivot from carbon monoxide poisoning to pregnancy. And you think, how can those two things go together? Well, carbon monoxide was an important story this morning we wanted to talk to you about because we want to make sure you know about the danger of carbon monoxide. Pregnancy can be a profound, joyful experience. It can also be scary and exhausting, like I know what I'm talking about here, folks. I'm a guy. But far too often in this country, it's deadly. And today, we're going to explore America's problems of maternal and infant mortality. There are especially problems around this rooted, though, in racism, and what that means about our conversation today. This conversation must be honest, empathetic, focused on understanding why African Americans experience so many more challenges around this moment that should be full of joy and laughter, and instead can be full of some pain and sorrow. So joining us today is Dr. Charlotte Smith, who is the Director of Birth Equity for the Department of Obstetrics and Gynecology here at the University of Kansas Medical Center and Health System. She's also the founder and director of the Kansas Birth Equity Network. She's the co-founder of Kansas Sisters and Brothers for Healthy Infants. You're like a founder. founder. We also have two of our OBGYNs from the health system, Dr. Carrie Winnicke, the chair of obstetrics and gynecology here at KU Med, and Dr. Angela Martin, the medical director of labor and delivery, maternal fetal medicine specialist, and a high-risk pregnancy physician, is also here with us this morning. Good morning. This is a team. This is the A-team here today. Importantly, we're also going to be hearing from Hannah Bird, who just gave birth to her son Atlas here at our health system back in December. Good morning to you, Hannah, and thank you for being with us on the program this morning. It's awesome that you're here. Hey, the statistics of maternal death in this country, they're trending in the wrong direction. The newest CDC data show that how the COVID pandemic made things worse. This graph shows the overall maternal mortality from 2018 to 2021, and it's getting worse every year. And to be clear, it's getting worse even before the pandemic. Had a really big jump, though, in 2021. Here's what happens when you break down the data by race. Deaths are 2 to 3 times more common in black women compared to white women. That is not acceptable. Dr. Smith, we're going to start with you with this big question. Talk to us about why this disparity exists.
Well, that is a big question. I think the disparity exists mainly because of racism, and when we talk about racism, we talk about it in a systemic way, how there are policies and procedures in place that were built to oppress a certain people, right? And so we're not just talking about individualized racism, we're talking about systemic racism and the things that happen. And when we look at racism, what's happening is we hear a lot of women say, I'm not heard when I go to the doctor, they don't listen to me, they don't follow my plans. And the reality is sometimes that is not just in the hands of the physician. We hear people talk about problems at the front desk, but this is also in the hands of how our systems work, our HMOs, how health insurance works. And so the reality of that is that when we are impacted by this racism, and black people deal with this every day, and so it causes stress. My friend Dr. Tracy Johnson likes to talk about weathering. When we talk about racism, what happens is racism impacts the black body, which causes stress, and that leads to weathering. And what weathering is, in an analogy, is a Jenga game. So with black people, if you play Jenga, there's little pieces you put together, right? And so every day, there's little pieces of racism that happens in your life, whether you're stopped by police, or you go to the grocery store and someone follows you, or you're in your community and someone calls the police on you, or someone mistreats you. There's little things that happen. And if you pull one piece, just like in a Jenga game, then that person falls apart. And that's what happens with the black body when we experience racism over time. Because we see that black women, regardless of their education, regardless of their incomes, regardless of where they live, regardless of the fact that they go to seek prenatal care in the first trimester, they still have worse outcomes than white, Asian, and Hispanic women who are poor, who never finish high school, who seek prenatal care either late or no prenatal care. And so the reality is it is the stress of the body on the woman's body. And so we see that most of the maternal mortality is contributed to cardiovascular disease, directly linked to stress on the body, right? We also see that most of this maternal mortality that we're seeing today is directly linked to postpartum depression, which is depression is stress and anxiety that happens in the postpartum period. And so that is linked to whether or not women are able to seek care within that time, or if it's just a stressful situation. And so we don't talk about traumatic issues that happen when people are in the hospital, and we don't give them care for those issues. So we have to make sure that we're looking at it from all factors. But it's definitely related to systemic racism that happens in our society.
Thank you. That's a great explanation. And so I think this point about socioeconomic status, so some people say, well, it's just about money. It's not just about money.
No.
Talk to us a little bit more about how that data can show that.
Yeah, so socioeconomic status is definitely, money is a part of that whether you have money, but it's about your education, it's about where you live, it's about where you work, play, and live, right? And so it's your surrounding areas. It's also your social environment, whether or not you have social support. So in the place that you live, if there is support for you and your family, right? And so that is your socioeconomic status is centered around like where you live, what schools your children attend, what grocery store you can go to, whether or not there's the ability to walk in your community, right? Where you live determines a lot about your health. Then we talk about where you play. Are there parks in your community? Are you able to get to certain things? So if your socioeconomic status is low, do you have a vehicle? Transportation in Kansas is not that easy to take a bus somewhere, right? And so, and then where you work is whether or not you have health insurance. We do not have Medicaid expansion. So whether or not you have health insurance in our state, whether or not you have a job that supports leave. So whether you can have maternal leave and paternal leave, whether or not you can take off from work when your children have an issue in school, right? Whether or not you can breastfeed at work. We talk about breastfeeding and how that is a contributing factor to having a healthy infant and a mother-child bond, right? So, but whether or not you can do that is determined by your socioeconomic status.
Yeah, it is. There's so much of this and so many layers to it. But I love that analogy. And you don't want to compare racism to Jenga game, but your point is that how it happens every single moment of every single day and in so many different ways. And it just feels oppressive in its explanation, because it is oppressive. Yeah. Dr. Winicki, what do you teach future OBGYNs about this problem, and how do you deal with it from a standpoint of being a chair of a department where you're trying to teach all these learners?
Well, I think that, I look back now, it seems moons ago, and I don't think this was brought up in our training when I went through residency.
Wasn't
right?
in medicine either.
And it wasn't probably even in medical school either. Yeah. So I think the biggest thing is that we are open to talk about it, and we realize that there's a problem. And so we talk about it openly. And so we've addressed it in a couple different ways. And that is just we do things like, so a grand rounds or an M&M. We specifically look at issues of cases that are related to racism and talk exactly how those sort of, situations affected care. We have started a program in our department that Dr. Smith co-leads called BEST, so Birth Equity Scholar Track. So we take a group of really committed residents across different departments that are going to go through a 1 to 2 year long program looking at our community and racism and bias and working to form those partnerships and relationships. When we look at our outcome data, we look at race disparities here at our own health system. But I think really the big thing is that there's a problem, and we aren't afraid to say that out loud, and we're working through ways to try to address it.
Yeah, that is impressive. This is a really pretty innovative, in my mind, innovative program. I don't think it's elsewhere in the school. Are any of the departments doing what you're doing?
So for the BEST program, no. This is something that Dr. Smith and Dr. Kelly Crace, our residency program, really started at the first in the nation. Yeah. So we are championing an opportunity for our trainees really to take time out of their busy training schedule to focus on these issues and its impact of healthcare and how they can make a difference in their community.
That's a big deal. So how do the students and the residents, how do they receive it?
Oh, the students receive it very well. Like, the students are excited that they get, taking their time to really learn about the different factors that are related to these maternal outcomes. So they're not just learning about research and the data and the questions, they're learning about policy. So the students were so excited about policy. They want more. They want to learn more about policy and how policy works and how it impacts health. They're excited about the opportunity they get to spend 40 hours this summer working with an organization that works on Black maternal and child health in our community, to build that collaboration, to build that partnership. And they're excited that we meet monthly, and this is actually funded by the OBGYN department. There's no funding for this program, so Dr. Winicky is funding it out of her chair's fund, but that reality that the department is investing in it, the students are excited, and when we meet on a monthly basis to talk about different topics, they're there, they're asking questions, they're ready to do their research projects, and they're excited about the opportunities of building more collaboration with the community.
Yeah, that's a big deal. I'm glad you're here to do that. So Dr. Martin, what are we doing for patients here at the health system to help overcome some of the things that Dr. Smith has outlined for us?
Yeah. So first, as Dr. Winicky alluded to, we're not afraid to look at ourselves. So we address our own implicit bias. We provide implicit bias training for all faculty and staff that are involved in labor and delivery, anti-racism training. We also hired a director of birth equity to help us through this, which I think is really unique and really important. We also created an OB quality committee, so we meet once a month and we look at various benchmarks and outcomes, and we see if there's certain patterns or trends, ways that we can incorporate appropriate policies and procedures to keep patients safe. And then throughout the department, there's several research projects going on looking at racial disparities during pregnancy, delivery, and the postpartum period to hopefully help minimize those.
So where do you still have to, what's the next phase where you're going to take this program? What are you going to do next?
That's a great question. I think just coming up with new innovative ways to look at implicit bias training and anti-racism training. When we do find patterns in our own data, publishing that and systems to improve that, if we do find improvement, sharing that data, I think would be really important.
Yeah, it's a big deal. Okay, so we're going to be back with Hannah in just a moment. I bet she's out to take care of Atlas for just a moment. So let's talk a little bit more about some of the toxicities and things. So do you think, Dr. Martin, is this making a measurable difference in how the students and residents are viewing this challenge?
Yeah, I think it is making a measurable difference in how they view these challenges, because a lot of the information that they're getting because of the BEST program is information that they would not have gotten throughout their medical training. They're not really getting the information that talks about racism and how it impacts the outcomes, or the history of African Americans and how that has been contributed to the outcomes, right? They're not looking at, in their medical curriculum, they're not looking at policies and how policies are basically put in place to oppress a certain group of people, or the political game around reproductive rights. They're not getting that in their curriculum. So I think it definitely changes the way they see these outcomes and what they feel impact the outcomes. This is not just one thing. We only focus on healthcare, but there's so many different factors that go into play when we look at maternal outcomes.
Yeah, that's a big deal. Okay, Hannah, welcome back to our program. I say welcome back. Welcome to the program. Thank you very much for being here. You gave birth to Atlas back in December. How are you doing, and how is Atlas doing? I think you brought Atlas onto the set just a second ago.
Yeah, I heard him crying a little bit in the back, so I went and got him. But I'm doing really well. I'm actually really appreciative to be here today. But we're doing really well, and he'll be actually 4 months tomorrow. So
that's a big. By the way, I love that name. Atlas will be very strong, something I never was. So that's a great name. So you said before the program that pregnancy scared you a little bit. Tell us about what scared you.
The scariest thing for me was just not being there for my son. The thought of me not going home to be there with my child, that was kind of the scariest part for me, and trying to find good health care. As Dr. Smith was saying, being a Black woman in America and trying to find good health care or good place to have your child is really scary. It's one of those things that you don't really think about until it happens. So
what did your doctors tell you about staying healthy during pregnancy? What were the things they asked you to do?
Just make sure that I'm taking care of me, because if I'm not taking care of me, I can't take care of anyone else. So just making sure that I take care of me, drink plenty of water, try to stay on or stick to like a healthy diet. But that's pretty much it. I had a really good, healthy pregnancy, thank goodness.
And Hannah, do you have friends who have had a different experience with their pregnancies and for whom it's been a challenge than some of the things that Dr. Smith was outlining?
Yes, definitely. I actually know a few women who have had a difficulty pregnancy and just the whole experience as a whole. So that was definitely one of the things that I didn't want to happen to me. So it was really important that I found a good provider for me, not only for me, but for my son. So when I found KU, I was just more than ecstatic, basically. I love the staff. I love everything that came with KU, even the aftercare after I had him.
Well, you're very kind, so thank you. And I know we have a pretty amazing OB team here. They're pretty remarkable folks, and so hats off to everybody. But really, I appreciate that you're telling us that story. So since December, what kind of follow-up care are you getting now? What are you doing?
I did have my 6-week postpartum. I did go up to KU, and then my son was being seen there in the pediatrics. So, yeah, I'm pretty much getting, or I was getting care at KU. So. Good.
And Atlas is doing well, it sounds like.
He's doing really well. He's growing. He's getting big, and like you said, strong. So I'm very grateful for KU. I ended up in a scary situation. Actually, I had a emergency C-section, and I was even scared laying on the table and just kind of being there, not knowing what's going to happen. But after everything was, over with and finished, you can barely even see my scar. I'm healing well. So I am like really appreciative of KU. I tell all my friends now, like, hey, if you have, even if you're not pregnant, I would really say go to KU. Go to KU.
Well, listen, you're good. We're just going to hire you for the system so that you can continue to tell that story. But so it sounds like you had some challenges with the pregnancy. If you had to have an emergency C-section, and do you remember much about that?
Yeah. So I was in labor for about 2 days. I wanted to do it natural, and I kept telling his father that if I can't speak, that his father would have to be the voice for me. So that was another scary experience. Just, I was just thinking, what if I can't say anything, or what if I can't speak up for myself? I would need someone to speak up for me. So I was telling his father before I went in, like, hey, if anything happens, you have to be the voice for me. But like I said, luckily everything went well. Like I said, your staff, and there was an amazing team. Even after I gave birth, everything was just more than what I could even imagine or think that, I would get.
Yeah, that's a big deal. Well, Dr. Winicki, it sounds like there were some challenges for this. What caused an emergency C-section?
I don't know Hannah, so I can't comment so specifically on her situation. But when we think about globally in the United States about causes of maternal mortality, we know that there are some common themes that run across in the causes of mortality in the United States. And those would be most commonly cardiac defects or cardiac problems, infection, hemorrhage or bleeding a lot, and then like a DVT or PE or a thromboembolic event, and then hypertensive problems. So we see all of those, and then as we sort of mentioned earlier, here at KU we're really looking about if there are disparities of our patients and which of those we might be seeing more common on different people here.
Yeah. Talk to us a little bit about Dr. Ryan, talk a little bit about what preeclampsia is and how that can affect, and does it affect African American women more?
Yeah. So it affects about 2 to 8% of all pregnancies. It is a little bit more common in our Black birthing people. It's a hypertensive disorder that's directly related to the pregnancy, and it can really affect any organ system throughout the body. Most of the time when patients are diagnosed with preeclampsia, they ultimately deliver and get to take home a healthy baby, but it is associated with severe morbidity, so it can cause severe kidney disease, liver disease, stroke, seizure, which is what eclampsia is. So it can be really dangerous if it's unrecognized or untreated.
Yeah, it's something we want to make sure people get close care of. And another reason where if there are ways you can't seek care that you outlined, Dr. Martin, those are, I did that twice today. I cannot get the Martin Smith thing right. And I even worked out today. Usually I'm pretty sharp.
It's okay. Dr. Martin's amazing, so I can.
That's all good. So, but you mentioned some of those obstructions. So if something like preeclampsia is sneaking up on somebody, you're not getting follow-up care, it's going to be hard to know and get that treatment.
Right. Yeah, there's postpartum preeclampsia as well, and so if you don't have, luckily we have an extension of Medicaid up to 12 months after, but if you don't have Medicaid expansion, your last appointment is between that 6 to 8 week period. And a lot of times what we see in the literature, of course you'll have to ask the physicians, is that postpartum preeclampsia is diagnosed after that, and so women are not able to seek the care that they need.
Dr. Martin, follow up with that.
Yeah, so there are certainly problems that can occur in the postpartum period, and that's why, postpartum follow-up is really important, and certainly expanding Medicaid here in Kansas would be really important to reduce maternal morbidity and mortality for sure.
Yeah, I think we would all agree that that would be a really important step to trying to improve the health care of Kansans, is just making sure they can actually have access to health care with Medicaid expansion. All right, so then there's the whole mental health side. What do you guys, talk to us a little bit about that, about moms and postpartum depression and anxiety. Who wants to start with that?
Well, so pregnancy and postpartum is a scary time. It's for a lot of people, they haven't experienced this before. They're taking care of another individual. You're tired, all of these things, and we really do see a lot of changes in mood during pregnancy and postpartum. That can actually lead to mortality issues as well. So, and we do know there's disparities of our Black women and other individuals that we see. So we are during the course of the pregnancy, we ask a series of questions, and we try to really identify patients that might be more at risk, and help them and give them more tools, etc. And then we also here at KU have started a maternal mental health clinic, specifically to get patients in that are expressing concerns, or we hear about concerns, to address this, because it is a big problem.
Just to say, I remember very well having a newborn, and I thought to myself, oh my God, this is the most stressful thing in life. And then we had two that were 26 months apart. I do not know how people with twins do it. I can't imagine it. Triplets, it's out of the park. I don't. How does that happen? Because you're sleep deprived. Both these young children need you so much, and it's just hard. Hannah, are you getting any sleep at night right now? Hey, there's Atlas. Show us Atlas. Hi, Atlas. Awesome. Atlas. You looking at your mama. I like that. So, Anna, talk to us a bit. Are you getting any sleep?
We're currently not getting any sleep, but it's honestly worth it for him, and just watching him grow and learn and everything. So it's worth it.
Yeah, my wife and I. So my wife was breastfed for the first year for each child, and so she would feed, but it was my job to take them out of the bed, change the diapers, whatever, and then she would breastfeed the night. And so we had that thing down every 3 hours. And I'd like to say we're used to that by being a physician, you're on call a lot. But in that case, there's nothing like having a baby at home. That is just the most maximum stress you feel, I think. All right, so Dr. Martin, I want to talk a little bit about suicide and overdose deaths also being a factor. Talk to us a little bit about some of that I know you got involved in.
Yeah. So Dr. Winicki alluded to the fact that mental health can be tied into maternal mortality, and so it's really important that we screen women for postpartum depression and risk of suicide. And we have implemented several policies here at KU for screening and hopes of catching those women and reducing maternal mortality from that cause. But yeah, it's definitely something to consider.
And we focus a lot on maternal death. What other complications are out there from pregnancy? I know we talked about preeclampsia and eclampsia, but what else do we have to be nervous about?
Yeah, that's a great question. So, maternal mortality is kind of the tip of the iceberg. Underneath that is a lot of stuff. Maternal morbidity, and certainly when a woman suffers from a severe maternal morbidity, it affects the whole family and can be really dangerous for her. The same things that can cause maternal mortality cause severe maternal morbidity. So the things Dr. Winnicke mentioned, postpartum hemorrhage, obstetric hemorrhage of any cause, cardiovascular disease, hypertensive disorders, cardiac diseases, pregnancy-related infections are some examples.
Yeah, so Dr. Smith, you've helped create 2 different groups. We said before you were like the founder's founder here, and I was just pretty impressed. We were going through your credentials there. But Kansas Sisters and Brothers for Healthy Infants and the Kansas Birth Equity Network. Tell us a little bit about that work.
Yeah, so as Dr. Martin was mentioned, we talk a lot about deaths, but for every 1 woman that dies, 100 women suffer severe maternal morbidity, and that's really sick. That's really being really ill, right? And the reality is that we put a lot of responsibility on the physicians, but patients need support outside of the healthcare system. There needs to be community support, and so the Kansas Sisters and Brothers for Healthy Infants was really developed to create awareness around infant mortality, Black infant mortality when I was in Wichita. And the reality is those are fraternities and sorority members, Black fraternity and sorority members that already do community work within the community and are committed to the improvement of those communities. They oftentimes come from those communities that are highly impacted by these outcomes, and they already have existing trust in the community. So working with them in collaboration to create awareness was the perfect start of this work, because it's really grassroots issues that they can educate their community, right, on understanding what infant mortality means. They can educate their community on the importance of co-parenting and fatherhood, and they could have conversations with their communities around birth equity. And we'd have an event every year called Celebrate Day 366, and that was our opportunity to allow them to talk to their communities about these issues, but also to change the conversation from death to celebration. So we celebrate more and more Black babies living past that 365-day mark every year. Now we have the Kansas Birth Equity Network, and that was developed because we were tired of people working in silos to do the work. Everybody's doing a different project, and there is truly no plan. So the Kansas Birth Equity Network brings together diverse organizations across our state, and by diverse that means the work that they're doing, not their race, brings them together to create solutions for Black maternal, paternal, and infant health. And the reality of that is that we want to stop describing our communities in a deficit. We want to start affirming our Black communities, identifying the strengths and working with those strengths and helping them to enhance that. And we have several activities that happen. We have our Black Maternal Health Week event that happens this week on April 15th, and that is our opportunity to work with our community, to affirm them, to celebrate. We have keynote speakers, we have vendors. It's really a place to create safety in being Black and understanding these outcomes, and also to have that peer-to-peer support. So there's other people that are sharing those same experiences in one place. So we have that, and we also have our Birth Equity Summit, which is another opportunity for us to come together and talk about birth equity. But one thing that I would like to highlight is the Kansas Birth Equity Network has a pot of funding that from Healthy Blue, where we will be funding community projects around our research agenda. So it's the opportunity for us to fund the community to do some of the work, to provide more services and more support to Black women in our community. We have a parent support group that meets virtually every week on Wednesday, so parents can come together and talk about any issues that they're having with a doula, and she's also trained to be a midwife, so we work closely with our community to provide these resources. We also partner to have a Black Dads gathering, which is once a month. It's called Dope Black Dads, so when you talk about dads, you gotta talk about them being dope. But it's the reality of we try to provide everything that we think a family needs to create that safe environment outside of the healthcare system for their baby, and we try to provide that education so that they know what to be aware of, and we try to provide that comfort. We have physicians that are a part of that are right here in our health system. We try to provide that comfort so that when they go to the hospital, when they go to the clinic, they can ask questions. So it's that setting where everybody's in one place, and you build that trust, you build that comfort to have the true conversations.
All right, this has been a remarkable conversation, and you are the founder's founder. And if you have questions about pregnancy and Black maternal health, please send them to us on YouTube, Facebook, or email. Those links are right here on your screen. Let's check in for a moment with Dr. Dana Hawkinson, Hawkeye. You know, Dana, they're getting real formal with you. You're the medical director of prevention and control, all that other stuff. I'm still going to call you Doc Hawk. I don't know if anybody else does.
Yeah, I'm getting it more and more.
It's stuck, hasn't it?
It happens on the floor, yep.
Good, I'm glad. All right, so talk to us about our numbers day and how things looking.
Yeah, I mean, things were looking pretty good. Again, I think it seems when we're both on, the numbers seem to increase a little bit. We had been in the mid to high 30s. We have come down to the 20s. Right now, we have 22 active infections, so 44 total, but 22 active, 3 in the ICU, and 0 on the ventilator.
You know, Hawk, finally we're tracking to the national data, right? For a long time, we hung in those 40s
Yes.
and 50s, and now to know we're down in the 20s and even the low 20s, that's awesome. Let's just hope it stays. You know, we're going into, this is the good time of the year.
Yeah.
There's no question in my mind, at least right now, that COVID has a little bit of a seasonal variance pattern. I think it's just linked to inside-outside a lot.
You know, I think that's right, and I think initially we just saw it circulating all the time. I think we are developing more of a seasonality, but I still think there will be higher rates of circulation of this virus, SARS-CoV-2, compared to influenza and maybe other cold viruses. But I think we are getting into a seasonality, and was just looking at a report, MMWR by CDC, talking about the seasonality of RSV. So even that seasonality, which normally was happening on a regular basis, seemed to get out of whack during the pandemic, but it seems to be going back to that as well now too.
So last week, researchers at the Chinese CDC, or its equivalent, finally published some of their data.
Yeah.
What do you think about that?
So this was originally the those sequences that were published on a public database. They were identified by another research group. At that point, the Chinese group had taken them off, but not before they could be downloaded and then sequenced. And what this showed was that there was a significant amount of other animals in these genetic sequences that were also aligned or maybe associated with the virus. This is more data and information to help support the fact that the pandemic started with a natural spillover event, probably multiple spillover events. That is not necessarily the conclusion that the Chinese authors came to, but that is continued to be supported by most of the other research community around the world. There is a good critique of this article on This Week in Virology or TWIV. It's a podcast. I would encourage everybody to go listen to it. But again, the bulk of the data continues to support that this was multiple spillover events that occurred probably at the Wuhan market there, where they were selling live animals, rather than other theories such as the lab leak theory. There's also one China continues to support, which is it came over in their cold chain, so in frozen food products, but there's really no data or evidence to support that. Also, we know that the FBI and the Department of Energy, I believe, has come out with saying that there is a possibility of the lab leak, but again, that is a low confidence, and even from what I understand, those two stories are conflicting. So the best data that we have available to the scientists and people who study this continue to support the natural spillover event for the origin of the pandemic.
You just say other pandemics, long before we had the ability to do cellular research, occurred as a spillover event from animals. And so it's not like a new thing that just happened.
Yeah, I mean, have you heard of SARS-1? That happened in the early 2000s. That was a very good example as well. So there have been other critiques and reviews about data to support the spillover events, the natural origin. I would encourage people to kind of go look at those rather than succumb to conspiracy theories at this point and things that are right now unsupported by the data that's available to the public and the other scientists around the world.
Yeah. All right. Let's turn now to Alexis. Alexis, what kind of questions are we getting out there today?
We have so many great questions, Dr. Stites, and we have some great comments. So I want to start with Yen Liang, who has a question about amniotic fluid embolism. Yen would like to know if it's still a significant cause of maternal mortality, and are there any effective ways to prevent it in the U.S.?
Dr. Martin.
Yeah, that's a great question.
I got the Martin Smith thing right this time. I just want to point that out this time.
Yeah, that's a great question. So amniotic fluid embolism is fortunately very, very, very rare. But when it does happen, it can be catastrophic. So the mortality rate when it does occur is very high, but it's a rare event to begin with, which is great. It's unpredictable, it's unpreventable when it does happen, unfortunately. So.
Not really great ways to prevent it.
No.
Unfortunately, most people do survive it. There are a few that don't, and we work together a lot. My history here as an ICU doctor with our terrific OB folks. So, all right, Alexis.
Jeremy Yenser has a question. Jeremy wants to know, what's the biggest challenge you're seeing in all of this, convincing people that this actually is the reality, or getting people and organizations to act on that reality?
Oh, that's a great. Okay, so how are you doing with the convincing of the reality of Smith?
I think that it's simple when we talk to the Black community, because they're aware of these issues. A lot of people have had experiences that they may not have shared with other people, and so when they think about what happened or a story that they've heard, then it's easy for them to get involved. I think when you're talking about others getting involved, you have to really talk to them about the reality of the data. What you got to share the lived experiences, because some people turn a deaf ear to the data. So you got to share the lived experience with them. But I think most importantly, the main challenge we have is getting people to support the fact that we really need to focus on Black families first, because they are the ones with the most disparities. A lot of times we have people say, well, what about this population? And my answer is that we will focus on the Black families until those disparities improve, and then we'll focus on others. But there are many of organizations that focus on others, and so I tell them, come to the table with us, because when Black women thrive, we all thrive, right? When one group is healthy, we're all healthy. And so once we focus on those disparities, we're able to do better.
So did you have trouble getting this program started? I can't remember if you started this as a program director or chair.
Chair. I had very little. It was all Dr. Smith and Dr. Crace. That this was all of their idea. I just agreed and supported, but I will not take any credit for this. This is really these two amazing women's ideas.
Kind and appreciate it. But what about, did you have pushback from the school or any other? Did anybody say, what are you doing this? What?
Not that I know of. Most people were like, wow. And we've taken it to the national level to share with other programs.
Yeah.
And people are mostly like, wow, why didn't we think of this?
Yeah, why hasn't this been gone on before?
Correct.
Yeah,
So
you were slow.
we are working on dissemination so other people can really see what we've done. But once the idea has been proposed, it's amazing, because we have such amazing leaders.
So have you run into resistance? Did you run into resistance?
No, I think I proposed the idea to Dr. Winnicke, and at the time Ed Ellerbeck was our chair, and they both were acceptive of the idea. And then I talked to Dr. Crace about it, and she was like, let's go, because that's the type of leader she is. She's a really great leader, so we partnered. It's about the collaboration, though. I think when we think about these programs, it takes a collaborative effort to do them. So you put a researcher with a physician, and you're able to really make things happen, because you have to understand both sides of it. We understand the data and the research, but they understand the schedule of the resident. So there was no pushback, and there's been no pushback. People are really impressed, not just within our system, but our community is impressed that we have this program, and that makes them feel better about KU. Because of some of the false things that they've heard. I'm sure they're false, but that makes them feel better about receiving care at KU, and it makes them feel like KU is ahead of the game. They're doing things that other institutes aren't doing, and so that's definitely, now I hear people say, that's a place I want to go to, which makes me proud.
It is. It's a great thing. Alexis.
Our viewers are loving this topic. Ann Sellentrop writes, what an outstanding program. And Georgianne wants you all to know that Atlas is adorable. And
Atlas is adorable.
That's right. Got a question from Jean Reardon. Jean wants to know, what causes preeclampsia?
Dr. Martin.
Yeah, that's a great question, and the answer is we're not quite sure yet. The hormones of pregnancy, some of the changes, inflammation, the way the placenta implants into the uterus really early on in pregnancy sets the stage for preeclampsia to develop later on. So we don't exactly know what causes it, and the only treatment we have right now is delivery. And so, when we catch it, we monitor it very carefully and then decide when the best time is to deliver.
Yeah.
We do have something that might reduce the risk of preeclampsia, and that's aspirin. And so for patients who have risk factors for preeclampsia, we're often recommending that they take 1 or 2 baby aspirin a day throughout their pregnancy.
This aspirin thing, it's that drug that keeps coming back for one indication or another, time and again. It's interesting. And so why does aspirin work for preeclampsia?
Yeah, it has to do with the way that placenta implants really early on in pregnancy in that first trimester. It kind of changes some of those hormones and helps reduce the risk of preeclampsia.
All right, Alexis.
I have one last question from Maggie. It's a COVID question, a vaccine question. Maggie wants to know if there is any word yet if another bivalent booster is needed 4 months after the last bivalent booster.
Okay, Hawkeye. Well, how quick? I'm hearing 6 or 12 months, depending on how immunosuppressed or immunocompromised you are.
Yeah, that is true. The FDA is expected to make some announcements in the next coming weeks, and their thought was that if you are immunosuppressed or have some other comorbid conditions, then you could possibly get a second updated booster dose at least 4 months after that first one. But we are also waiting for general recommendations as well. And again, hopefully those will be out within the next few weeks. That was the last I had heard from the FDA. So we are waiting. We know that has been a hot topic for especially people that are at higher risk of disease from SARS-CoV-2 infection as well. So we are awaiting, and I think that is the expectation, is that there will be a recommendation, especially for those that are at higher risk or immunocompromised.
All right, this has been just a remarkable program. I love it. First of all, I want to say thank you to Hannah and Atlas. Now, can Atlas wave? Because I want to wave to Atlas. He looks pretty cool there.
Yes.
There you go. All right, brother.
Say hi.
I like it. Oh, there you go. He's doing what babies do. Excellent. Hi, Atlas. You'll remember this day forever, Atlas, or not. Hannah, final thoughts about the program today.
Honestly, I'm just really grateful that you all had me today and that we could talk about a touchy topic that needed to be addressed. And I hope that, in the future, more Black women do turn to KU and just know that they'll get the best treatment and care. So that's pretty much all I wanted to say.
Well, thank you. You've been great, and Atlas is awesome. So thank you for being with us this morning. It's really nice of you to share your morning with us. Dr. Martin, final thought.
Yeah, I feel really fortunate that I'm in a department that takes this seriously and does the hard work of looking at our own biases. And I look forward to continuing to work on health disparities in our own department moving forward.
Yeah, excellent. Dr. Winicki.
Well, I think it's, coming back to thank you for bringing up this topic today, for allowing us to talk about some things that aren't easy to talk about, and it's only through talking and acknowledging that will make a difference going forward.
Yeah, no, I agree. It's about the conversation. And Dr. Smith, man, founder, you're in the conversation.
Well, I want to thank you for allowing us to come on and talk about this issue that's very sensitive, but near and dear to our hearts, because we know that we have to address it. And those who want to get involved, I say, if you're concerned about this issue and you want to make sure that mom, dad, the family, and the baby gets to celebrate the baby's first birthday, then get involved. Come out on Saturday. We'll be at Memorial Hall from 11 to 1 for our Black Maternal Health Week event. We have a proclamation from the governor and a video about this being Black Maternal Health Week nationally and for the state of Kansas. And get involved in the Kansas Birth Equity Network. We'd love to have you. We're here to make sure that Black moms and Black dads and Black families, with whatever the structure is, and Black babies survive this reality and are healthy. And I'm grateful to work for a university that allows me to do the work, not just within these four walls, but out in the community.
Yeah, and that's awesome work. Doc Hawk.
Yeah, not much more to say other than I think we just probably need to end with some more cuteness overload and just putting Atlas back up there. I think that'll be best.
This is the best. A great program this morning, and I just want to say thanks to all of our guests and for all the great work that they've done and the great work that moms do, as Hannah shows us every day. Thank you.
Coming up tomorrow on the Morning Medical Update. With Parkinson's disease, shaking, spasms, and tremors can rob you of a normal life. And new research finds it's more common than we realize. I'm Jessica Lovell on the next Morning Medical Update. One patient went years without proper treatment until she sought a second opinion. Thursday at 8.
I'm Alexis Del Cid on the next All Things Heart.
I think our biggest concern was having open heart surgery. Just the sound of it is scary.
Surgery to repair your heart with the help of a robot. The alternative technique that had this patient recovering from home just days later. Thursday morning at 10.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.